Good evening. I'm Dr. Max Gomez, the senior medical correspondent for CBS here in New York. And welcome tonight to tonight's version or iteration of an ongoing series of webinars that we are doing here for Columbia Children's Health. And tonight we have a really interesting topic, and it's an update on COVID-19 and children, which of course is a very hot topic right now. And when I first heard that we were going to do this, I said, well, haven't we really covered everything we could possibly cover here? But actually, no, it's a moving target. This thing keeps changing on us. And so I think it's very important that we have this particular update. Before we start our, excuse me, before we introduce our panelists, a couple of housekeeping things. The entire webinar is being recorded tonight and will be posted on the YouTube channel in Columbia Children's Health, so that you'll be able to go back and review it, so that you can, it'll be like an open book test. You won't have to actually memorize or take notes on all of this. And I've asked our panelists if I can address them by their first name, so that we can do this, keep this in a sort of informal and conversational way. And now, if you have any questions, you can post them either in the chat box or in the Q&A box there, and I will try to catch them as they come up and feed them out to our panelists as we go along. And to introduce our panelists, let's start with our distinguished Dr. Melissa Stockwell.
Thank you all so much for joining us today. My name is Melissa Stockwell. I'm the Chief of the Division of Child and Adolescent Health here, as well as an Associate Professor of Pediatrics and Population and Family Health, and have an expertise in vaccination. And I'm so excited to introduce my co-panelists today. So Erika Berman Rosenzweig is a professor of pediatric cardiology, as well as our vice chair of clinical research and the director of our Pulmonary Hypertension Center. Josh Milner is a professor of Allergy Immunology and is our chief of the Division of Pediatric Allergy Immunology. And Edith Bracho-Sanchez is a professor in my division. She's a professor of child and adolescent health. She is also a primary care pediatrician, and I am as well, I should have said. And she is director of our pediatric telehealth services for our ambulatory care network for our hospital. So welcome.
Terrific. Thank you, Melissa. So let's start out with, and I don't want us to cover everything all at once here, but let me play a little bit of a devil's advocate here and say, the infection rates are going down, Omicron rates are going down, we're opening up again. Why do we need to do yet another update here? Everybody is fine, we're okay, let's just go for it. Who wants to take a shot at that? And then we'll have the other panelists tear you apart.
I guess I'll start off. I think it's always helpful. I think families and parents always have questions. I think this is actually now a good time when we're not in the heat of the moment of having a peak to stop and take stock and kind of think about COVID and vaccination. I also think that many of you have probably heard many of us say that COVID is going to be something that becomes endemic. What does that mean? It means it's something ultimately like flu or other viruses that we see that are with us, and there are going to be times there are peaks and there are times that in between the peaks, and we need to sort of begin to move into that stage and be comfortable with there'll be times we need to do things like social distancing and potentially masking, and other times where the rates are low that we can kind of, as we are right now, kind of backing off from those things. And so I think it's always a good time to stop and talk about that.
And would it be fair to say that we should look at this as not, okay, we're at a certain stage, we change things, and then we can't go back?
Yeah.
We may very well be going back and forth depending on what the virus decides to do.
Absolutely. And I think that's kind of how I've been framing it a lot, is, we have a scenario A, B, and C. So, we're in scenario A when rates are low and we can, be more open and kind of do all the things that we've all been, itching to do. And then there's maybe scenario B, where rates are starting to go up and we may be needing to implement some other things. And then scenario C is when we're in the middle of a peak and we really do want to do everything that we can to stop infection at that point. And I think it's helpful for me, and I think my colleagues, to think of it that way, that it's not a start stop, but we kind of move fluidly in and out. And I think schools have really done very well with this. They're remote, then they were hybrid, then they're in person, and they have felt very comfortable kind of moving back and forth. And I think the rest of us in healthcare and in society need to be comfortable with that as well.
The rest of you buy that? You're okay with that, or do you have any qualifiers that you want to add to that? Just pretend that she's not the boss.
Well, I couldn't agree more. So let's put it that way. But one other thing that regarding the pandemic and the future, and I think many of these panelists know all too well, is really potential long-term sequelae of COVID. And I think we are really just hitting the tip of the iceberg now. We at Columbia, with Melissa and Josh's leadership, have put together a group that's going to be studying this formally and through the NIH Recover cohort study. And I think we really do need to pay attention to things that are even potentially subtle that may creep up as far as previous exposure to COVID. So, we're sort of in uncharted territory and learning as we go, but hope to share that as we learn more about the long-term impact.
Mm-hmm. Erika, we're going to come back to that, I think, to dig a little deeper into that in a bit. But Edith, Edith and or Josh, let's go back here to what was hot just recently, which is Omicron. And the Omicron variant seemed to be sort of the harbinger of really bad things to come, and we're never going to get any better here. But let's talk about Omicron and potentially other variants. What have we learned from our experience there with Omicron?
Yeah, I think we've learned a lot of things that we didn't necessarily know at the beginning of this pandemic. I think number one, this virus mutates. It is what it does, and it is what it will continue to do, unfortunately. I think it's also important to know that the virus is not necessarily going to mutate from the last variant that we all became familiar with, right? So I think there was a little bit of a narrative going around that, Omicron was more mild, and then therefore the pandemic was dying out and the pandemic was over, and then future variants were going to evolve from Omicron and become more and more mild, and that's how the pandemic was going to end. And boy, wouldn't it be nice. Unfortunately, that may not be how it works out. And in the future, whenever a new variant hits, and unfortunately we will have more variants, it may not, evolve from Omicron, and that may not be the case. So, and to sort of talk a little bit more specifically about Omicron and the way that it affected children, I think, we were reassured, I think, as a country, right, looking at the data about Omicron potentially being more mild. However, when it came to children and with all of these variants, right, with Delta and with Omicron, when you think about the populations that were hardest hit, it includes the unvaccinated, and the unvaccinated, unfortunately, still includes many children, because children under 5 don't yet qualify for a vaccine, right? We don't have a vaccine available to offer to them. And also because kids who are above 5, unfortunately, our rates of vaccination are not great. So I think, on the one hand, we had sort of this narrative of Omicron as more mild, but then when you really dig in and see who's being affected by these variants, Omicron and Delta when it happened, right? Which, Delta was not more mild, but variants in general, who are the ones getting hit? Unfortunately, it's people who are not vaccinated. And unfortunately, our kids, many of our kids are in that category. And then, the last thing I will say is that it's we've also learned that we have to be careful about the way that we think about children, and the way that kids in general, right, respond to infection. So I think there was, again, a narrative and backed by data, right? substantial narrative saying, Omicron tends to affect the upper airway and therefore it's more mild in adults. And that's wonderful and that's great and held by data in adults. Unfortunately, in kids, that sometimes meant that those upper airway infections in kids who have smaller airways did land some of our kids in emergency rooms and even hospitalized with things like croup. So we just have to, and bronchiolitis even. So we just have to be careful about, when we say, the next variant will be more mild, that may or may not be the case, or, the current variant is mild. Wait a minute when you hear things like that, because that may not hold for children. And I think we also have to know that more variants will come and that we will have to adapt, as sort of Melissa was saying, with the different scenarios that we've learned to sort of live with.
So Josh, as our kind of resident immunologist here on the panel, to taking off to what Edith was saying here, we can expect more variants. They won't necessarily mutate in the direction of benign, I take it. Although I guess that is often the direction that viruses tend to mutate. But I've also seen, again, taking a little bit from what Edith was just saying, a tendency amongst the public and certain so-called experts to cherry pick data to support what they want to, the narrative that they want to push forward, i.e. it may be it's an upper respiratory virus. It's going to be easier on everybody and so forth. But the data that applies to adults may not apply to children, right?
Yeah, no, 100%. I think, the cherry picking is to an extreme that, you can convince anybody of anything in an elevator, right? And that's how it, although people tend to go on a lot longer than the elevator ride. But regardless, there's interpreting the data is very important, and interpreting the data for child X is ultimately what this boils down to. When you look at large populations, it gives you ideas about what's going on. But of course, part of the narrative for why Omicron was milder was that we'd already been vaccinated and people had been infected by Delta not so long before. And the timing of when people have been vaccinated and or boosted, and the timing of when the previous wave came through has as much to do with what's going to happen with the next variant as what the variant itself is composed of, and whether it has mutated in one direction or the other. There have been very wide differences in the way each of these variants has impacted countries based on sort of things being in phase and out of phase. And, what's going on in Australia, well, it's totally different. It was fine in Australia. It was a problem in, Zimbabwe, so, keeping in mind that timing of vaccines and the timing of the infection, independent of genetic differences and socioeconomic differences, and again, independent of the virus differences, those pieces are rather critical. And so, or just even add to socioeconomic differences and viral differences that really have to be thought about whenever interpreting any big data. When we want to bring it home, we saw a bunch of kids in the hospital during Omicron, period, full stop. Kids who don't usually show up in the hospital, full stop. And that's what it boils down to. It was not like a regular cold season or a regular this season or a regular that. There were a lot more kids coming in and complicating the situation. So I think that your point about avoiding the cherry picking is like as important as possible. We all have our little bellwethers that we use. I would just look at the line of people at the urgent care clinic around the corner from my house. And I didn't need to look at the New York Times for what the frequency was, but you know what, that was the Bronx. And maybe it's different somewhere else. So I think absolutely, it's just one of the most critical points in understanding and interpreting the data and understanding and interpreting experts.
Right. And to your point, you said that kids showed up in the ED and they were sick. And these are kids, as you said, who were otherwise apparently healthy and you wouldn't normally expect to see them get that sick. Is that a fair way to put it?
So again, I would say there was a population like that, right? Who there's no explanation for why they're coming in. There are also people who are going about their lives with whatever conditions they have, who normally don't show up in an emergency room getting sick, but are at risk for it. But they got it because of how incredibly infectious this was, and because they were in areas where the guard was down. And so that's another way of putting it, that yes, that's exactly the person who gets sick, but that was avoidable, right? For that person to be getting sick. So it's not normal that they're showing up in an ED. So I would put it that way. And the other piece, of course, remains obviously the post-acute issues that Erika brought up and that we should hopefully discuss more. Those very definitely show up in plenty of folks who there's no other explanation for what's going on, and change their lives completely. And I think that's important. And that's a lot of people. That's more people than showed up in the ED, I can promise you that. Wow. And then the other thing is the multisystem inflammatory syndrome in children, which almost universally showed up in folks who didn't really have major medical issues prior. It had predilections for certain ethnicities and conditions and things like that. The good news was, in that particular sense, there was a lot less MIS-C this time with Omicron than we saw with previous peaks, especially given the number of cases we saw in Omicron compared to the number of cases we had with previous variants. So it's possible, and I will just say possible, that you were at lower risk from Omicron and maybe even Delta. I think the data are a little bit more solid there, that fewer people did come in, and everyone who came in was unvaccinated. Just about. So again, it was avoidable, and it may have been that the numbers were lower because people were vaccinated. And that's an important piece to obviously keep in mind as well, right to the point of cherry picking. The observation that there were fewer kids doesn't mean that it's just because the virus was better. It was perhaps, again, vaccination, houses with vaccinated people, the whole 9 yards.
So Erika, I want to get back. I very much want to dig into some of these differences here that Josh brought up. But before we get, since we're on the topic of vaccines, Melissa, let's talk about vaccines. They're not universally available for kids at this point. 5 and older, under 5. What do we tell parents? I mean, I think they're kind of confused and at a loss here. What do we tell them?
Yeah. So I think that for I'll do the under 5s first. I think the expectation is that in April, there'll be data released from the trial for the Pfizer BioNTech vaccine for the under 5s, and then move to FDA review and ultimately hopefully approval for that age group. That would be for 6 months to 23 months, and then 24 months or 2 years to less than 5. So that will kind of encompass then our whole age from 6 months and older. We don't generally vaccinate similar to flu for under 6 months because they have ideally some protection from, particularly if their mother was vaccinated when she was pregnant with them, to kind of be able to support their protection. So I think hopefully we will have some good news in April about that. I actually, I know there was some confusion for families. We thought that we would have approval a little bit earlier. I actually think that this was a really important demonstration of the thoroughness of the whole process with the FDA and the approval that, everyone said, let's take a pause. There's new data that's going to come in. This trial data is actually going to happen faster than we thought, primarily because of Omicron. So there was more infections that were happening in that age group during the trials. They were able to get more data, and really, again, I think just demonstrates the rigor and the thoroughness. That we do have a vaccine for 5 vaccines of different doses for 5 and older. As Edith alluded to, our vaccine coverage really isn't where we want it to be for those younger kids, particularly 5 to 11, and even there are a lot of potential kids. We'll kind of do better as we get into the adolescent age group. I know that families there was data in the news about understanding about the protection of vaccination, particularly for adolescents and for the younger age group. I think there's a couple important points. The first is we know there is waning immunity. So among the adolescents, the waning immunity of protection against an infection, not so much against the severe disease, but if you get the booster dose, that immunity goes back up. And we at Columbia were actually part of the CDC study that just came out, MWR, that looked at that information.
This is booster dose for whom now?
For adolescents, so that there's waning immunity, the booster dose for the adolescent, brought back the protection.
Okay. For
the 5 to 11-year-olds, of which there's, they just started to get vaccinated in November. There was a question about the effectiveness, not against protection, but the very serious things. So I want to talk about that, but about protection against just general infection. I think it's important to remember for vaccination, we're not necessarily looking for no infection, right? Even against things like flu. What we're looking for is protection against those serious things that have you end up, like Josh mentioned, in the emergency room, in the hospital, and honestly against children dying. And there have been almost 1,000 children who have died from COVID, and that is primarily preventable with vaccination. There's also a really important piece about MIS-C, which is what Josh was talking about with the multisystem inflammatory syndrome. There's very good data that vaccination protects against MIS-C, which is a very, very severe complication of infection, and not necessarily the children who are at high risk for complications. These are, children who may even had very mild infections. Some didn't even know they were infected at all and end up, with a very, very, very serious reaction to having been infected. And so again, I know while it can be confusing and we all wish, right? We all wish we had that magic bullet vaccine that, you were protected forever and never get infected. The most important thing to know is that these vaccines are doing a very, very good job of protecting against those severe, against hospitalizations, against serious infections and those complications. And therefore, I cannot, as strong as I can say that we really, really do recommend that everybody get vaccinated against COVID. I can say that my children have both been vaccinated. My children have both been boosted. And I know all my colleagues as well. And so we 100% along with the Center for CDC and the American Pediatrics do think the single most important thing we can do is really to get children vaccinated against COVID.
As soon as they're available for whichever
age they're available for your age group.
We're talking about.
Absolutely.
And one point that you made there that I think often gets lost, but it came up in something else that I was talking about with people is that I think the general or often the understanding in the general public is that a vaccine is going to protect you against all infection, meaning you're not going to get sick at all. And I think people need to understand that what we're talking about with vaccines, particularly for this, is protection against hospitalization, death, really serious disease.
Right.
You may still get some infection, you may become symptomatic or whatever. That's not what we're talking about, right?
Right. And you do get some protection against that too. So I don't want to say you get no protection, but what we're looking for again is the really significant things. There's also, I think, just to harken back to something that Edith said before, which I think is really important, is there had been kind of this feeling that, the children don't get COVID. Not true. We know that there have been over 12 million children who have, infections in children. Then, kids don't get sick from COVID. Not true, right? As Josh mentioned, we've known that all along, and certainly, Omicron, the same has been for Omicron. And so I do think that, and I think we've all said this many times, and I know Max, you've said this too, that it's really important to be thinking about children and these misperceptions, because we do a disservice to our children, to our patients, to our families when we families and don't sort of understand that there is a risk to their child. There's a risk of infection. While rare, there is risk of serious illness, and that's what we're trying to protect against.
Right.
If it's okay, I want to just add one quick thing to that, which is just that with respect to the things that are rare. So if we talk about MIS-C, even if we've gone from 1 in 1,000 to 1 in 3,000 children, right? That is a lot of children. And many of the childhood vaccines that we mandate are because of the catastrophes that happen as the result of measles, mumps, rubella, and chickenpox that happen at about that rate. In other words, that's why we mandated everyone, because children can die. And as I think it was important to point out, it's not acceptable when hundreds of children are dying who don't need to be dying, right? That's just not acceptable. When Michelle Walensky, the CDC director, put it that way, that's an important point. But I think, really the point is that the things that are happening are at real rates that we have all those other vaccinations for as well. It just happens to be that chickenpox and measles doesn't break out nearly as much as COVID. But what we're really vaccinating for was those severe cases. That's an important thing. And in the case, for instance, of measles, it is the truth that measles actually impairs your immunity for the rest of your life.
Wow.
Okay. Right. I mean, and it's clear that is what ends up happening. And we're like, oh, well, I had a measles and no problem. Well, when you look at the population, the people who had measles did have impaired immunity in different ways. And you just don't realize. And that's yet another reason why we have a longer life expectancy for lots of folks. And that's, of course, the concern with long COVID is let's just make sure we're not giving somebody something that they're going to have for the rest. If you can avoid it, that they'll have for the rest of their life if they could be protected against it with vaccination, which it is.
Important. Yeah, an important point. Very important. Erika, I don't want you to fall asleep over there. So what we want to do here, if I heard Josh correctly a little bit earlier, it sounded like he was saying there's a difference between MIS-C, multi-system inflammatory disease in children, and long haul COVID. First of all, kids get long haul COVID. And secondly, there's a difference between this MIS-C and long haul COVID in children?
Absolutely. Again, just to clarify, the MIS-C, this sort of constellation of really a severe effects or impact of COVID that can actually land a child in the intensive care unit in something we call vasodilatory shock, which is essentially, a form of shock that requires very, very close medical attention, fluids in some cases. They may have, a ramp up of their inflammatory markers. And, if it's identified quickly and the patients, receive the care that they need, for the most part, the patients, will recover. But again, that's a very, that is a sort of a life-threatening illness that we want to prevent. And I think to everybody's point, vaccination. That is, and that is very different from what we're referring to as sort of PASC or post-acute sequelae of COVID or long haul, long COVID. There's sort of been a lot of different terms, and I think hopefully eventually we'll settle on one. But this is really referring to these longer term symptoms that patients are complaining of. Children, adults, patients who've been exposed to COVID of all ages, typically after even a month of the infection, they're complaining perhaps of fatigue, joint pains, rashes. I mean, the list is long, and it could, ranges. You correct me if I'm wrong, it almost hits every system from, neurologic to, again, pulmonary, shortness of breath, cough, chronic cough. And this is something that we can talk about this as well as the perception in the community of, depending on who you speak to, about whether this entity really exists. And I can tell you, I'm pretty sure these panelists believe that it does, because we've each been, seen patients that have real troubling complaints. And I think it is a call. The NIH recognized that the CDC, that this is a real issue that may impact our patients for years to come, and that we need to really have be studying it now retro and prospectively, so that we can really define it. Because I think right now there's not even one uniform definition, characterize it, and really understand the long-term impact of COVID. So again, I'm, Melissa and Josh and I are part of a large investigation specifically to look at the long COVID. So I'm sure they have some insights as well.
And I think just want to
go
add
ahead,
to what
please.
Erika was saying is that, Erika and Josh and I have been, had the great privilege of being part of this consortium, and of which there are patients and family, who are part of this consortium. And when, these parents talk about the way their children are really suffering, for sure, I not only believe that it exists, but I believe, we have a duty to understand it and ultimately figure out how to, treat it and prevent it. And a lot of these, some of the kids, the symptoms might be mild and they get better. And some of these kids, can't go to school anymore. They're not unable to function. And there's nothing, it's terrible and horrible when that's an adult. But when it is a school-age child, when it's a teenager who has the rest of their life ahead of them, for something, that happened after, an infection that, other people are saying, doesn't affect children, it's really, really heartbreaking. And something that we really do want to just prevent from any other children suffering from this.
And I think you kind of answered my next question, which was, it sounds like many of these sequelae are things that can be treated, but may in fact have a very long tail in terms of of their effects. Is that a fair way to put it?
Unfortunately, no. I mean, I think that some of them we actually don't know how to treat it. So I think once we're seeing these symptoms, and I'm actually going to defer this to Josh, because he's actually caring for a lot of these kids. But sometimes actually, unfortunately, know that we don't have the answer yet on how to treat it. And these we can maybe treat some of the symptoms for some of the cases, but other cases that we can't. But Josh, I'm gonna hand this off to you.
Well, I would just take a step back to say that I think one of the reasons why people don't think, why you might have a camp that thinks that there is no such thing as long COVID, is because they'll say, gosh, I see patients like this all the time. And yes, I see patients like this all the time. Way before long COVID was cool, we had people who had identical symptoms, happening out of the blue in an otherwise healthy person. And then, for months or years of a lot of completely life-changing suffering with the same types of concentration and focus and fatigue and inability to tolerate exercise and pain in lots of different places, not feeling like you can get good air in, and becoming very reactive to lots of things. It's absolutely true. We've seen it a lot. And it's probably going to end up being that COVID is one of those viruses that can trigger it. And before, everyone just said you were crazy because they didn't know what virus triggered it at that point in time. Okay. But concretely, we actually have data now that COVID infection itself can be worse acutely, but also long COVID can be worse if your acute COVID infection, which may not even be that serious, triggers you to reactivate mono, EBV, right? And so it's measurable and it's quantifiable that those who ended up having their mono reactivate, which happens lots of different times and people don't even realize it. And they keep saying, I got mono again and again. And really what it is it's the virus in your own body waking back up because your immune system has been weakened, in this case by COVID, but other viruses can do that too. And we just didn't pay attention to that enough. As you saw across the news, that people are finally realizing that EBV probably really does have a direct contribution to developing multiple sclerosis, right? A long-term change to your immune system. Well, and even if the EBV is no longer around, you still have multiple sclerosis. And here again is just having it reawaken. And because of your acute infection can then lead, even if it goes away eventually, can lead to all sorts of disruptions of immunity and other symptoms that end up lasting for a long time. And so I do think that's an important framing, that you're absolutely right that this isn't just because of COVID. There are lots of other reasons. And that's, by the way, why over $1 billion is being poured into the long COVID question, because it also covers chronic fatigue and many of chronic pain syndromes, many of the things that for years people have said has been happening to me, and it happened after I got sick from something, and everyone just says I'm crazy at this point in time.
Right.
And so I think that's it. So, and so there may be interventions that result from that, and if we don't know about it, we will never be able to know what those interventions are. And there are certain symptoms where there could be some symptomatic relief if you just, paid attention to it. And one of the examples which I can say I saw in front of my face, in addition to now it being in the literature, is that for some people going on antihistamines help them extraordinarily, because one of the manifestations of their prolonged COVID was sort of a propensity to have allergic issues more and to have reactions more. And so some of them went on antihistamines. It didn't cure everything, but it actually made a number of their symptoms substantially better the moment they went on them. And I think, again, don't all go running to give every patient with long COVID an antihistamine, because you'll have a lot of disappointed people. But I'm simply pointing to the fact that there could be symptoms that really can be covered and thought about that maybe you wouldn't have before, if we think about it and take it seriously.
And a lot of sleepy kids.
Not those antihistamines.
Oh, okay. All right. Fair enough. Edith, let's talk about an area here that often is sort of ignored, maybe because it's hard to quantify, to really wrap our brains around numbers here, and that's the mental health impacts of the pandemic. What do we know about it so far, and is any of this quantifiable, or how do we deal with that? It seems like it's really fuzzy and hard to get our hands around.
It is. I would say what we know is this is bad. We're in bad shape. Kids are, and families as a whole, right, are really struggling in many ways. And some are struggling more than others, I should say, right? So it's not sort of an equal, like everyone is sort of seeing the same effects. It's really nuanced. And I think it's part of what makes it so hard to quantify in so many ways. But I think the best I can explain it is, we've all sort of been living in this heightened state of anxiety for the past 2 years, right? And I think at the beginning, we all sort of thought, we have to, it's a pandemic, there's a lockdown, there was very, everyone was sort of talking about it in the same way, with the same level of alert and sort of urgency, right? And then I think we've all sort of diverged a little bit as things changed, right? And for some of us, because we have support, because, of the specifics of our jobs, we've sort of been able to figure out ways to sort of cope and thrive, despite the fact, right? Because it doesn't mean that our anxiety, our fears about this virus, and the many things that we're juggling at the same time went away. But I think for many of us, we've sort of been able to figure out ways to cope and deal and function in the world, right? Okay. I think, unfortunately, that is not the case for many families. And I think because this has been going on for so long, we often forget that, right? I think, many of us have adapted and found ways to cope, but that's not always true for some of the families we care for. And so, when I think about it, it's sort of, think about, the mom, and I'll, very candidly share that I'm a pandemic mom. So I have a 5.5-month-old. And I think, for some of us who have become parents in this pandemic, and, parents of young kids, parents of teenagers, the isolation and the challenges that come with either new parenthood or, with your, older school age child or your teenager being isolated have been many, right? So the challenges have been real, and they have been many, and they haven't stopped coming. And so I think all of that, right? It's just, and I sort of frame it in that way because we sort of had to take a step back and think about what's happened here, right? And what's happened is that the state of anxiety and alert that we're all living in hasn't gone away. At the same time that many of us became parents, at the same time that many of us have continued to raise kids and have teenagers at home. And so, when you look at all of that, it's really no wonder and totally expected that we would see higher rates of anxiety, that we would see higher rates of depression, that we would see higher numbers of kids that are coming to our offices, frankly, in crisis, right? And so it's been challenging, it's been heartbreaking, and it's a complex problem to fix now, and it is one that we have to fix at the same time, right? So it's
What do we do? What do we
challenging.
do?
Right, I know, right? Like,
give
that's
me
a million
something.
dollar question. What do
Help
we
me
do
out
about it?
here. What can we do?
So I think, the first thing is we have to acknowledge how big of a problem this is, right? And I think many people are, and thankfully, I think we're in a place in our society and in our country where we can talk about this, and it's taken very seriously, right? Like mental health and the way that we talk about it.
It's gotten a little better anyway.
It has, and sort of the stigma. There's still tons of stigma. Don't get me wrong. There's so much stigma, and we see it even in reluctance of families to get help and to get support and to seek that support sort of proactively, right? So there's tons of stigma. It's not to say that, but it has improved in many ways from what it was. So that's the first thing, right? It's like we have to acknowledge that we're all sort of dealing through or working through many challenges and dealing with things that are constantly changing and in this heightened state of anxiety. But then we also have to devote resources to sort of helping kids and to creating systems that are sustainable long-term, because I don't think this is a problem that we fix in the short term. And what I mean by that is, we have to make sure that we have access for kids who are, of course, in crisis, who need our support, whether that is short-term, long-term. And then we sort of have to find ways to effectively find the families who aren't necessarily coming forward and saying, we're struggling, we're having a tough time, and find ways to recognize what it looks like in some of our families, right? Because it doesn't look the same in every family. It's, it's the kid who hasn't come to appointments, and you just keep seeing, they didn't show up, they didn't show up, they didn't show up. And as primary care pediatricians, we do this all the time. What's going on here? Like, why are they not coming? We need to find someone to reach them. And so it's like, how do you, I think for us as providers, as pediatricians, as healthcare workers, and it's like, how do we create systems that find all these things, that spot these things, and that sort of, go in and say, when a kid hasn't come in this many times, we need to figure out what's going on with this family, because families are just dealing with so much right now. And that was a very, very long answer, but I really do believe it's a complex problem, and one that is urgent and one that's going to take a lot of creative thinking to fix.
So is it fair to say that step one is recognizing what some of the signs and symptoms are, perhaps, but also almost just as importantly is there is help out there, and we need to be able to guide families and adolescents, if they're going to do it on their own, which they may very well decide to go it on their own, where and how to seek help. Is that a fair? I'm trying to get my hands around something concrete for families and for kids.
Yeah, no, absolutely. So the first step is absolutely being able to recognize the signs that a family or a child or a teenager is having, difficulties when it comes to their mental health. And when I say recognize the sign, signs means that, we have to understand that it's not always going to show up as a sad child. We sort of, many people expect that, right? Because we as adults will sometimes seem sad. For a kid, it might be acting out. For a kid, it might be not paying attention to school. For a kid, so some of those more nuanced things we have to really educate ourselves, and as parents and as pediatricians, we have to learn some of those signs. And then yes, knowing where to go and look for help is absolutely important. And I just would say that for us as pediatricians and people who are in conversations about systems, we just have to create those systems and establish systems that work for our families, because it's not very helpful if someone knows the signs and comes to you with all of the signs and says, I think my child may be struggling with depression or with anxiety, and you don't have a system to sort of help them through that and guide them through that and get them to treatment and see that they are able to get to a better place.
Got it. So I'm getting a couple of questions here that I want to make sure that we get to, because there's sort of hot button issues, and I see that we don't have a heck of a lot of time here left. There are several questions that are coming in about mRNA vaccines, their safety, differences between Pfizer and Moderna, even though they use the same mRNA sequence, the doses are a little bit different and so forth. what do we know about safety? People keep getting a little freaked out about long-term effects of mRNA, which are the vaccines that are really approved at this point. What can we say about that? I guess, Josh, that lands in your bailiwick.
Well, it also lands in Dr. Stockwell. So in as much as we're both on a vaccine safety committee, but she's a much bigger deal on that one. But I would just say that the point in terms of long-term safety, this is something that comes up all the time, and you will often hear people saying, how do I know this is something different? How do I know? I can tell you from the immune system's point of view, if something doesn't pop up in about 5 or 6 weeks, maybe 8 weeks, it's not going to be popping up. It might last a long time when it pops up in 5 or 6 weeks, and that's a long-term sequela, but there are no surprises that come up from this or pretty much anything else when we introduce it like that, and especially given the way that mRNA vaccines actually work is in some ways even more natural than what we do when we give all kinds of other vaccines, just for the record. Not that they're not safe either, but it's actually a more natural way of inducing the immunity. And so I think that that's the most important point I always like to say is we know at this point in time what the long-term side effects are. We know what the rare long-term side effects are, and and they show up within 2 months. So it's not like there's additional shoes that are going to end up dropping here with respect to that. One of the biggest concerns is the endocarditis, oh, help me, it's too late.
Myocarditis.
Thank you. Sorry, Erika, geez, you're the cardiologist, and that's why. Just that can show up, and it can show up in certain populations. It's enriched. I would point out that everyone was worried about giving it to younger children. They've had less, without question, of the endocarditis, of the myocarditis that followed the vaccine. And if you want to talk about, what about long-term things? Same thing, COVID. Like whatever you're worried about that vaccine doing, we've already proven that just about everybody can get it, as Omicron showed us, and the next variant likely will if we don't. Those are the things we don't know. And protecting against that, even if you get that initial infection, it's already clear you're less likely to get MIS-C. So there's one long-term side effect that can end up being prevented by vaccination, even though the infection itself might not have been prevented. And the list will go on. So it's a matter of balancing having a sort of clear-eyed view on what you worry about, and understanding those risks in a more clear-eyed way, as opposed to, unfortunately, what is overwhelmingly rhetorical concerns that get raised.
So Melissa, wait, hang on, because I want to come back to you on a slightly different topic. Okay. But first I want to get over to Erika on something, because one of the big things that people ask about is after my child has gotten sick, has an infection, when is it okay for them to go back to school, go back to playing with their playmates, to interact with grandma and grandpa, nana and pop-up, that sort of a thing? Do we have kind of any kind of guidelines that we can follow there?
We actually do. And again, this has been a bit of a moving target as the sort of isolation for COVID changes. But if we go with the most recent, American Academy of Pediatrics has a wonderful algorithm that you can easily access, and with work with the CDC. And in general, the guidance is that, while a child is isolated, regardless of whether this is a mild or moderate or severe infection, they're not really supposed to exercise. But then you can typically kind of break it down into whether a child had an asymptomatic or a mild infection. And in that case, many of those children, after their, a phone call to the pediatrician about whether there's any evidence of one of the more ominous things, such as heart-related symptoms, chest pain, palpitations, syncope or fainting, shortness of breath, should be elicited. And if there's no signs of that or complaints of that, in general, those children, once they're off isolation, can go back to their usual play and resume activities and sports and so forth. For those, however, who have maybe, called a pediatrician and they're complaining of, my child's a little more short of breath or is having chest pain or, anything unusual, then that really should warrant a visit with the pediatrician to not only try to elicit whether any of these symptoms are truly, worrisome, do a physical exam and even an electrocardiogram if there's any concern of any cardiac related symptoms. And in that case, if all of those are fine, that child again can resume play. If there's anything suspicious, I think then that is a referral that should go to the pediatric cardiologist. But for children who have more significant symptoms, so moderate symptoms, they end up maybe in the hospital, maybe they, but not in the intensive care unit. They've had fever for maybe more than 4 days, myalgias, aches and pains for more than a week. You want to take that a little more serious and certainly, again, no exercise while they're having these symptoms and while they're on isolation. But those children should visit the pediatrician and at that point, they're going to ask again specifically about any cardiac related symptoms, do a physical and electrocardiogram. Once again, if they're cleared, you typically will wait 10 days till after the onset of first symptom or positive test, but those patients in general can go back to physical activity. If again, any concerning signs of symptoms and an EKG is abnormal, you're going to send those children off to the pediatric cardiologist who can do a more in-depth exam. And certainly for those kids we talked about, Miss C, for any children who are, have a severe COVID illness, that's a whole other story where you're going to restrict activities for somewhere in the order of 3 to 6 months. And so it has to be individualized. There's wonderful guidelines. As I said, AAP has them posted, and that's what we typically will refer to for our kids.
Mm-hmm. So Melissa, let's talk about the other hot button issue that grows out from what Erika was talking about, is masks in children. Should they, shouldn't they, shouldn't they, and when?
Sure. So I think this is one of the things that we kind of started off with when do you kind of implement and de-implement. So now that in communities where rates are very, very low, a lot of the schools, including in New York City, have lifted mandatory or made masks optional. That being said, there are many children and families who children are still remaining to be masked because of their own individual risk or the risk of family members they might have. I know there's a question about what if there's a younger sibling who's too young to be vaccinated. There are a lot of families who are choosing to have their older kids remain masked because they don't necessarily want to introduce COVID into the household. And some of this research we do is on household transmission of COVID, and we for every kind of variant for COVID, but particularly for Omicron, we definitely saw that once it got one person in the house got it, definitely was able to be spread to other children in the house. So, if there's someone in the house who's immunocompromised, who not yet to be vaccinated, you mentioned grandma and grandpa. A lot of people are choosing to, for their children to still remain masked because they don't want to introduce, potentially an infection. That being said, there are other families. And I think that's a fine choice right now when rates are very, very low, about potentially time to kind of think about times when masks are off. That doesn't mean forever though. I think as we talked about earlier, we have to be comfortable with when the next variant comes and rates to go back up, that might mean that masks come back on, and that's okay. That I think is something we have to be comfortable with and really understand what is the data on the ground.
Forward and it's two steps forward, one
and
step
kind of
back.
and kind of see and be comfortable with that, and similarly with indoor dining or mask mandates or those kinds of things, and as a community really understanding when are certain things okay and when are times that we need to kind of dial it back to be able to decrease cases.
Are there some kids who are more vulnerable, different populations that are more vulnerable, other than of course the unvaccinated? But aside from that, are there?
Yeah, I mean there are health there's a list of kind of children who based on their health condition could be more particularly at risk of more severe outcomes from COVID. Certainly those who are immunocompromised, we want to be very protective against. And then the people who are older, so those who are 65 and older, for example, are also potentially and particularly 75 and older, potentially high risk. So I think, looking at your family, looking at your family's health, I can say my kids did stay masked this week in school. We tend to kind of have the highest level of protection. Some of their classmates didn't, and that's okay. Because rates are very low in New York City. Let me add. I think that went
underlying conditions are the main things that will put kids, other than being unvaccinated, that will put them at risk. Is that fair?
Yeah, and I would say, if you're unvaccinated, certainly I would very, very strongly urge mask. But again, if your household contacts are unvaccinated, or if they have, they're immunocompromised, they're, again, maybe potentially, older people, you really are very concerned about infection, then that would be important. And again, that's because rates are low now. So the chance of COVID circulating as rates go up, and they can, there is this, concern about the new Omicron variant. I think we have to be comfortable looking at the data on the ground and making those changes. And whether that is in a couple of weeks or a couple of months, we just don't know that yet.
Josh,
clarifying immunocompromised, to answer Max, you were asking about the specific reasons why a child would be at risk. Immune compromise could be because you're born that way. Some people with immune deficiencies have it. Some people don't actually have a problem with COVID. And then being obese or type 1 diabetic, even as a child, is a risk factor for severe COVID, period. And then immune deficient, it could be because, like, say, someone cancer and on chemo, but there also are a number of immune modulating drugs that people can be on, like biologics or immune suppressants if they happen to have an inflammatory or autoimmune problem. Some of those at certain doses are sufficient to substantially increase the risk for developing severe COVID.
So Josh, as long as you have the podium there, let me ask you one other quick question here, which I hesitate to ask because I know it can be something that's just going to explode here, but I can't let it go without addressing it. And we're going to go over a few minutes here. I understand that we try to keep it to an hour. We're going to go over a couple of minutes. In Florida, the governor has suggested, the way it's being interpreted, that kids shouldn't be vaccinated. I know the official language was they may not need to be vaccinated, but that's not how it's going to be interpreted. How do you respond to that?
So I think, this all boils down to, do we know that being vaccinated is safe? Overwhelmingly. Do we know that being vaccinated is going to prevent a population against having disease that has children show up in the hospital, not because of maternal hysteria or paternal hysteria, but because they're actually getting something that COVID gave them? Yes, we know they're going to be protected, and therefore the benefit outweighs the risk, and that's the end of the discussion. People may have personal preferences that are different. The part of the equation about whether they're going to be more or less likely to, well, okay, fine. You're immunizing a child so that someone else in the house doesn't get it, or someone in school won't get it. That number may be lower than what we would have hoped. That the number of people, but it is a measurable protection. It does wane after a certain number of months in time. We will probably be getting a vaccine that has different sequences in it of mRNA so that they can keep up with the variants, which will end up prolonging that. But in the meantime, there is a measurable protection even now for any child to get vaccinated. It's that simple. And so if you want to encourage people not to, that would seem to be a public health complete error. If you want to just show exactly that there is protection that's measured and have people decide in that regard, there is that as well. And in terms of mandates, again, that's a public health discussion. It's a public health issue. But for the simple question of, is the benefit outweighing the risk? And the answer is yes, then I really don't understand why you would say there's no benefit. That's not true.
And I think I just want to add one thing, which is just to add from before. There have been millions and millions and millions and millions of people, including children, who have been vaccinated. And so this, I think this idea of this is a new vaccine. We've had more children vaccinated with this vaccine than many, many other vaccines that are out there. And we know a lot about it. And what Josh said is true in the vaccine safety world. Really, it's that we look at this 42 days, that 4 to 6 weeks after vaccination, because that is really the window where things come up if we see anything. And there are millions and millions of children who have been vaccinated who are past that window. And so I would say we probably know more about this vaccine than many, many other vaccines. We know a lot of vaccines. So I really do think families should feel very reassured about the effectiveness, but also the safety of the vaccine.
And my panelists tonight, they know because we've done this before, I usually ask them for a little take-home nugget, a pearl of wisdom. But it sounds like, with your permission, Josh and Melissa, we've gotten your pearl of wisdom, because I don't want to go too far over here. So, Erika and Edith, you guys are the ones who get to finish up for us. Edith, let me start with you, because it comes out of a question here from somebody in Elmhurst, but they said that adults, when it came to mental health, kind of got their life back, kind of. Kids didn't. Kids really lost a big chunk of their childhood, what we normally think of as rites of passage and growing up. Can you address that in your little, if you will, pearl of wisdom, something that we can take home and remember?
Yeah, so I think, in this, we have to find a balance, right? I think kids are resilient. Kids are incredibly resilient. And, it's the question I used to get at the beginning of the pandemic is, how is a child supposed to learn how to wear a mask? And now kids are wearing masks better than adults are wearing masks. I'm sorry to say it, but that is the truth, right? And kids learn, and kids adapt, and kids are resilient. And if we support them, right? Like, if we consider them, if we put them, if we're purposeful about thinking about kids in the next phases, in the next month, in the next couple of years, and we truly put their health and their well-being at the top of mind and sort of address it head on, I really, really believe the kids will thrive, and this generation of kids that went through this will come out the other end stronger for it, and truly just value human connection and everything that's wonderful about being together in a way that generations before them haven't, right? So there's so much positive that can come out of this pandemic, but we don't get to say kids are resilient, we did it, bye, right? We have to say kids are resilient if we give them the support and the resources, and we think about them in the way that we have to and we should as adults.
And kids will take their cues from adults and parents around them. And so it's really up to the parents to make sure that kids exhibit the resilience that is ingrained, if you will. Is that fair?
Absolutely.
Great. Erika, guess what? You get the last word. What do you want us to remember about our update tonight?
Now, I actually think that Edith just probably said one of the most important pieces, and I will have to echo that and my other panelists. I think that while children are resilient, often more than we are as adults, we need to pay attention. We need to continue to pay attention, even though this pandemic has waxed and waned, and we heard that it may turn into an endemic. And what have we learned? I think we've learned a lot, from again, vaccine safety to public health, messaging and so forth, and mismessaging, and how it's so important to encourage people to follow the science and not just what's the latest, and greatest on the news. So again, I'm thankful to be a part of the process that's trying to really analyze what we've all been through and move forward in the future, and hopefully, keep our kids as safe as they possibly can be. And, that's.
I knew that eventually we'd get around to blaming the news for something on this here.
But we love you, Max.
Yeah.
Wait, I want that record. Yeah, we are recording that. Good. Okay, I'm going to start back. Thank you, my panelists here. It has been a terrific panel, so important to, as you say, follow the science, not what the latest thing is on the headlines or whatever. It's so important. A reminder that this will be on the YouTube channel, Columbia Children's Health, in a short while, in a day or two, so we can refer back to it. And please do refer back to it. And remember, this is not set in stone. Some of what we said will change and evolve as the science evolves. Science is not just one answer forever. And I think that's it, except for we've been doing this for 2 years. And I can't believe that at the end of every webinar, I still have to say, please get vaccinated, wear a mask. Thank you. Have a good night, guys.
Thank you.